It's Health View on your talk station, News Talk 640 WFNC.
And welcome back to Health View. This is Dr. Angela Ruff, and again, our guest this morning is Dr. Alvin Atkinson. Dr. Atkinson, during our last segment, we were talking a little bit about some of the, the importance of the defibrillator to have around and know how to use it, or especially have your family know how to use it, if that's who you're with, in case you do have heart problems. But what are some of the other problems that you see as your specialty?
Well, the other major area that we haven't touched on so far is valvular heart disease, and in many areas of the world, a major problem still is rheumatic fever. It's a disease really of adolescence and childhood that then develops with scarring of the heart valves, and they have to have the mitral valve either opened or replaced, and the aortic valve frequently has to be replaced. That's very uncommon in America today, unless they have migrated, which is not uncommon in America today, from, say, Mexico or South America or Afghanistan or Burma. We see people with rheumatic valvular heart disease from other countries who now live in the United States. So that should always be kept in mind by medical people, and even relatives of people, that they, even though these diseases are uncommon, rheumatic fever being uncommon in America today, it's not uncommon in many other countries of the world. And it usually manifests itself in the 20s and 30s and 40s with shortness of breath and irregular heartbeats. But anyway, what we see in our practice predominantly in terms of valvular heart disease is degenerative heart disease when people are born with slight weakness in their mitral valves, sometimes in their aortic valves, and these mitral valves can be repaired. Occasionally they have to be replaced. Probably 80 to 90% of all mitral valves that are leaking due to degeneration of the valve can be repaired with various types of operations, and that's certainly preferable to replacing the valve. In older patients in their 70s and 80s, sometimes the valves degenerate, but they're really, because of they're sort of worn out, they need to be replaced instead of repaired. And then the aortic valve, about 0.5% of the so-called Northern European population, those in Northern Europe, and most Americans have come from Northern Europe genetically, will have a bicuspid aortic valve, and that valve, well, half of those patients will develop aortic valve dysfunction, either regurgitation or stenosis or both, and will start to cause problems with their heart. It will become enlarged or difficulty pumping, and they'll get shorter breath, get chest pain, and this can become a very serious problem leading to heart failure and even death. And once this problem is recognized, they frequently have a heart murmur, and if people are found to have a heart murmur, then they should get serial echocardiograms every year or two. Be sure that their valve is not deteriorating, and it's usually done by a cardiologist. And if the valve starts to show signs of excessive wear or stenosis, then the valve may have to be replaced, and we do many of those valve replacement operations.
Now, with mitral valve prolapse, I mean, a lot of people have this,
right?
But
well, they estimate somewhere around 1 to 3% of all Americans have some degree of mitral prolapse. So I'm not sure it's an abnormal, disease any more than red hair, but it's just a variation in human beings. But it's when it does become severe, when the valve leaks extensively, which can be determined now very accurately with echocardiograms. That valve begins to leak and shows major structural abnormalities, which again can be detected on the echocardiograms. There's some very good protocols that the valve should be repaired before there's serious abnormalities develop in the heart muscle itself.
Well, with the valve surgery, I believe Arnold Schwarzenegger had his valve replaced with the
I think he had an aortic valve because of a dissection, but I could be wrong.
Yeah. And so there are different donors that can be used for that.
Yeah, we sometimes have, in the past, we used human donors, so-called homografts. I think now that, in my opinion, that the artificial valves that are made from pig hearts and cow hearts and then treated with glutaraldehyde are just as reliable, and some of the long-term studies show they may even be better than human hearts. You have to remember that human hearts are taken from cadavers, and not different people are different sizes, and they can, kill 100 pigs and find the best 20 heart valves in those 100 pigs, whereas the person dies and they give their heart valve to science or for a company. That heart valve may not be as good as a pig valve. They're all treated with, various preservatives. So, human valve, you would think, would be better than a pig valve, but it may not be.
So you can actually order small, large, and medium?
Oh, yeah. You got every different sizes.
Yeah, that's something
Of pig valves,
right.
You can't do that.
No, you can't do that with human
valves.
right?
Human valves have to be ordered ahead of time, and that's another issue. You can't get them off the shelf.
Yeah.
And the preservation techniques and so forth are more difficult to maintain than they are with you might say, a semi-artificial valve, in which we take a biological valve from either a pig or from a calf and then treat it with certain chemicals. It's all very standardized now. And the tissue valves have been shown to last in excess of 15 to 20 years in many patients.
Wow, that's great.
So, and the great advantage, of course, of tissue valves over mechanical valves is tissue valves you do not normally need to take anticoagulation long-term other than maybe aspirin. Whereas all the mechanical valves thus far, there's some that are in development, but there's none that are proven that don't require Coumadin or some other type of rather serious anticoagulation, which requires careful monitoring.
Right. Well, is there any risk of somebody rejecting some foreign valve?
Very rare.
Yeah.
Yeah. The glutaraldehyde process neutralizes the antigens on the valve and make it the body does it's inert to the body's immune system. That's not true as much of human valves. Some of the human valves have a little bit of antigenic material, and some of the patients we've had have fevers and for several weeks after the human valve transplantation. So we've been somewhat reluctant. Another reason that I think our group at least is moving away from human homografts to these glutaraldehyde-treated xenografts, as they're called, because they just tend to have less immune problems, higher reliability, and their studies thus far show they may last better than human valves.
Wow. And you can order the right size.
That's correct.
Yeah.
You just get it off the shelf.
That's pretty neat. So how long the success rate of this type of seizure?
Well, it depends on the procedure, depends on the patient's age. We know that the younger you have heart disease, the less likely it's going to, for whatever reason, your body's developed this problem fairly quickly in your lifespan. And so you're more likely to get recurrent coronary disease if you got it when you're in your 30s, which is rare. You've got some serious metabolic problems, but if you get coronary artery disease in your 70s and it's taken you 70 years to get a blockage, it's probably going to be at least 30 or 40 maybe before you get this blockage again.
Right.
And the same is somewhat true of valvular heart disease. If you have to have a valve that's going to, pump 70 to 80 times a minute for the rest of your life, it's got to be a pretty durable valve. And we've been fortunate that the valve companies, through research and continual testing, have developed tissue valves now that pretty reliably, if they're put in over the age of 60, will probably last in the aortic position over 15 years. The mitral position may be a little less than that because there's more stress on the mitral valve than the aortic valve. But all these things are improving. We have better data every year on better tissue valves. Mechanical valves last almost indefinitely, although some of them can get scar tissue around them. And we've recently seen some patients that have scar tissue around a mechanical valve, and theoretically that was put in their 20s, and in their 40s or 50s have to have it replaced because of scar tissue. So there's no perfect replacement for the human heart valve. If you possibly can take care of your valves and your coronaries, you do it, because the best ones you get are the ones you're born with most of the time.
Now, with I think I've heard before that mechanical valve, you can almost hear it if somebody has that.
Well, some people can hear it. The valves are a little quieter than they used to be, and it is it bothers some people. Some people think it's it's kind of like hearing, it's good to hear your car running. It's not too good when it suddenly cuts out. So I used to have a patient says, well, does it bother you when you can hear it click? He says, no, it'll bother me if I don't hear it click.
That's right. So
maybe this person's spouse or someone else won't bother. But the valves, I think they've made them a little quieter than the design, the mechanical valves.
Yeah.
But honestly, we don't put in a whole lot of mechanical valves because the tissue valves have become so reliable and last a long time with the safety, increased safety of not taking blood thinners, which do have some risks. That the use of mechanical valves is decreasing pretty rapidly in this country.
Now, I read something interesting. It's on. You've got a great website, by the way, and I'm just going to give it out to those listening who may want to go to that to get more information. Their website is carolinacardiovascular.com. Anyway, it's a really great website. They go into great detail about all these different procedures. And but I thought it was really kind of interesting, an aside, I guess, is that to have this heart surgery, you don't necessarily have the split right through the middle, the incision that way. You can go through a more discrete path, I suppose.
Yeah, you can call it minimally invasive surgery. We have various operations where we go off to one side and go sort of through one rib and so forth. And that's probably has some benefits in people, so-called minimally invasive aortic valve surgery. I don't do a lot of that. I've done it for years for atrial septal defect repairs in younger people who want a better cosmetic result, particularly young women. And cosmetically, it's clearly better than a so-called median sternotomy because your incision is not quite as obvious to other people. But in terms of recovery time, it may be just a day or two less. There are certain patients that are too big or too wide or too thick, or the heart is in a certain position. So you have to assess what patient. The surgeon has to look at the patient, also look at the particular valvular heart disease, and there are other things can be wrong with the heart besides this given valve. I think that the straightforward 40-year-old lady who has degenerative valve disease, perhaps a so-called minimally invasive approach or even a robot may be, be a little bit, certainly cosmetically, would be beneficial to them. But the median sternotomy heals very well. It looks kind of terrible on a video, but it was developed for babies with congenital heart disease and has stood the test of time as an excellent incision that heals well.
Right.
It gives the surgeon excellent exposure to do a very relatively dangerous operation safely.
Well, certainly it's better than the alternative, right?
Right.
Doing nothing. But I just thought that was neat because I always thought that was the only way you could have access to do these procedures.
No, there's multiple access. And our group has done and still does various types of ports and accesses to do that. And the technology is still evolving. As most people know, there's robots. And Greenville Institution is sort of a pioneer in that at East Carolina. And that's fine. But the data is still not there. Long-term follow-up studies are still, we've only been doing it for maybe 5 years. And these valves need to last 20 or 30 years. And we don't know yet that the repairs or replacements that are done through these minimally invasive ports will have good long-term follow-up. Thus far, the data looks fairly promising, but it's not. We thought that the stents would be wonderful. They'd solve all the angioplasty problems, but then we found out that 20% of them re-stenosed within a year. So suddenly that wasn't too happy. And then we put in stents, and then we found out they re-stenosed, and now we have coated stents. So there's no free lunch, and we just have to work through each of these new procedures in medicine till we have good scientifically established results.
Well, Dr. Atkinson, I just can't thank you enough for coming on the show, and you've really offered us some great information and put it in such a way that anybody could easily follow and understand exactly what you're talking about.
Good. I hope it's been helpful.
Yeah. So again, those listening, if you'd like to get some more information or contact Dr. Atkinson, just get to their website, which is carolinacardiovascular.com. So again, thank you for joining us. And you've been listening to HealthView. This is Dr. Angela Ruff on News Talk 640 WFNZ.